Last but not the least. And RD, in a case of herpetic uveitis, is it a walk in the park?
Assalamu alaikum. Thanks a lot, Dr. Abdullah, for the invitation. Thanks, Dr. Mohammed Al-Omari, for the nice conference. Actually, my talk is about one case. It's like a 61 years old male patient, have herpetic uveitis, herpes zoster, and he was treated on valcyclovir since almost 1 year. With a very high dose because of retinal necrosis that was seen before and treated elsewhere. So he came to me with a counting finger 2 meters in the right eye. He had a mild ocular trauma. And this is the detachment, the OCT image. And I'll go quickly to the video. So I did actually a combined phaco-vitrectomy, removal of the vitreous, and you can see the honeycomb appearance of the tear and retinal necrosis. And you can see here even the blood supply is truncated and feathery in the central area. So a typical vitrectomy, nothing fancy, just removal of the vitreous, shaving of the vitreous base, and cleaning all the retinal tears. And they were plenty, not just the apparent 2. Actually, there was more than 10 small holes. So cleaning all of that, diathermy, then making sure to remove all the vitreous. And with such case, I thought it would be preferable if we can put silicone oil just to make sure the stability of the retina for a bit of time until everything will be settled. So this is the post-op image. Everything is fine. The visual acuity improved. Patient is happy. I'm happy. But it is not the end of the story. We can see that everything is fine. Then, as Dr. Hassan Dibi just showed us, epiretinal membrane started to develop, and not an easy membrane. It gets thickened and thickened, and the patient was postponing to remove the silicone oil. But anyway, we did it. I will move that because this is the first one. So let's move on here. Yeah. So this, you can see the epiretinal membrane, it's very thick. Under the silicone oil, I peeled this membrane, and you can see it is very tough, very thickened epiretinal membrane, but not to pull too much. Then silicone oil was removed. It's a hybrid technique. I use 23 to remove the silicone oil. Then ILM peel just to make sure that it is not covering. And you can see that when we remove the epiretinal membrane, the ILM was as well removed. And then I put PFCL just to have it as a third hand to stabilize the retina and to prevent excessive traction on the fovea or on the macula. I didn't have an OCT, intraoperative OCT, so I thought maybe there was a small macular hole, so I was eager to put an ILM flap over the macular area just to make sure that there was no tiny hole there and to prevent any post-op problem later on. Sometimes it is very difficult to get this sticky ILM and to put it on the fovea, but I managed to do that with a finesse loop. And with that, I concluded and put gas SF6. Just 1 minute, please. 1 minute. And with that, this is the post-op image, and the retina finally settled down without any further complication. Thank you very much.
Thank you, Dr. Ahmed. If someone has a question or comment, Dr. Yahya, please.
I'm not putting it back. I'm putting on the fovea because I thought there was a macular hole, a small macular hole. So it's a free flap on the central area only, not on the whole retina.
So for the
and
possible macular
sometimes
hole.
in such cases of extensive epiretinal membrane, when it is very thick to be removed, sometimes I think for Dr. Hassan as well, trying to remove the ILM from outside the epiretinal membrane and peeling the ILM with the epiretinal membrane on top. So to create the hole, because this is the scaffold of the epiretinal membrane. Thanks a lot.
Dr. Mohammed Zidi, please.
Yeah, I have a question for your case. For your first surgery, you are in front of retinal detachment secondary to RPT1, but you don't have classical aspect with the several hole and necrosis of retina. That's its changed. My question is why you use endoderma around under hole in this case, even if you don't have a hemorrhage or risk of hemorrhage?
Yeah, just for demarcation, and not only all the holes that I did for that, just 2 holes, the big ones, because I would remove the edge of it because it was a honeycomb. So I was peeling inside the hole itself. So I did not want to create any, especially these are superior holes. So I do not want to have any trickling blood from these 2 large holes.
Thank you, Dr. Ahmed. Thank you, Mohammed Zidi. Thank you, all of our speaker and attendees.